see the group to take us. Group 3 is ready. I can see the screen is already presenting. So kindly, group 3, can you just proceed?
Good morning. I'm going to be presenting on behalf of group 3. I'm going to present on shock. Okay. Under shock is a life-threatening condition which is characterized by widespread inadequate tissue perfusion, which means that the body tissues and organs are not able to get enough blood flow and oxygen. And this condition might lead to cellular dysfunction, organ failure, or potentially even death. It might also lead to cellular hypoxia, which means that the insufficient oxygen supply is given to tissues even though the blood flow is inadequate, and this might affect the organs. Under the pathogenesis of shock, this pathogenesis of shock is a complex and involves a cascade of events at the systemic, organ, cellular, and molecular levels. And it can easily be defined as the sequences of biological events or physiological disturbances, which might occur when now the circulatory system has failed to deliver oxygen or nutrients to tissues, which might lead now to the organ or cellular failure or dysfunction. And we are going to follow some initial steps from when the shock occurs, the cause, up to when it has reached a progressive stage. And the first one is initial insult or reduced tissue perfusion, and this might occur as a result of decreased blood volume when the shock has taken place. And this shock will vary depending on the type of what has caused that shock. It might be due to hemorrhage, infection, or myocardial infarction, which takes place when the heart muscles fail to pump the blood. What might trigger this shock? After the shock, the hemorrhaging or the other causes of shock has taken place, the tissue perfusion must take place because of decreased blood volume, and this condition is called hypovolemic shock. And this might take place when there's been a significant amount of blood loss, which is called hemorrhaging, and this blood loss might take place when there's been trauma, maybe someone has gotten burnt, or maybe there's internal bleeding. Also, it might also take place when there's decreased cardiac output, and this condition is called cardiogenic shock. This is whereby the heart fails to pump blood effectively, and this might lead to maybe that myocardial infarction. Another way is obstruction to blood flow, and this kind of shock is called obstructive shock, whereby there's a blockage to that blood flow, and it might be due to a blood clot, an embolism, or maybe also some collapsed vessels along the circulatory system. And also, it might be due to vasodilation or the maldistribution of blood flow. And this condition is called distributive shock, whereby blood vessels widespreadly dilate, leading to that condition of hypovolemia, whereby the volume of the blood has decreased, and blood may now be shunt down away into the capillary exchange beds. For example, you might go into septic shock, which has been caused by a systemic infection, which has led to now massive vasodilation, leading the blood to be shunt away from the capillary exchange beds. Or also it might be caused by the increased vascular permeability. There's also anaphylactic shock, which might be caused by a severe allergic reaction, leading to massive vasodilation and increased vascular permeability. Also, under vasodilation, there might be neurogenic shock, which might be caused by brain trauma or simply spinal cord injury. And this might disrupt autonomic nervous system and might lead to loss of vascular tone. Secondly, cellular hypoxia and metabolic shifts. Now this is the second step, whereby now the organs are receiving blood even though the blood flow is inadequate. And now this might lead to the inadequate, as you know, like for the breakdown of lactic acid, it requires like sufficient oxygen. When the oxygen delivery is inadequate, the lactic acid will accumulate and will lead to a condition called acidosis. And acidosis is a drop in the pH of blood. Also, it might shift to anaerobic metabolism, which now leads to that condition of acidosis. Thirdly, cellular dysfunction and damage. Now, as that hypoxia, which was undergone due to lack of sufficient oxygen, has taken place and it escalates, and acidosis has persisted, cellular function will now be reduced, and this will impair ATP production and might also lead to cellular swelling. Hereby now the tissues are starting to get affected. And under the fourth thing, now the compensatory mechanism will start taking place, whereby the body attempts to compensate, for reduced perfusion now, where the tries to compensate for that inadequate blood flow along the circulatory system. And this compensatory mechanism starts to take place, to take its effect by activating maybe the sympathetic nervous system to produce the norepinephrine. And this norepinephrine will increase the heart rate. And as you know, it will lead to vasoconstriction of blood vessels, and it will increase the blood volume. Also, it might activate the renin-angiostensin-aldosterone system and the ADH system, which helps to conserve sodium and water, and it will enable to increase in volume, to increase the blood volume by retaining the sodium and water. Also, you might compensate for this lack of oxygen or inadequate oxygen supply by increasing your respiratory rate. And this will help to reduce the acidosis in the blood. After the compensatory mechanism, we go to the fifth stage, which now progressive stage and failure of compensatory mechanism. Once the compensatory mechanism has failed, the failure of those maybe organs start to take place. And this is explained simply by saying that if the underlying cause has not been treated and maybe the compensatory mechanism has totally failed, some of the conditions which might take place is the worsening hypotension, whereby the blood pressure will drop. Also, severe metabolic acidosis. And this, when the pH of blood has really increased severely, the buffering systems will be very overwhelmed, and acidosis will have really progressed so much. Thirdly, it might also increase capillary permeability and damage blood vessels, and they will start leaking and shift liquids into the system. And also, it might also cause microcirculatory dysfunction, whereby the small blood vessels like the capillaries will become impaired. Inflammatory response in many types of shock, especially the septic shock, whereby we said it is caused by a systemic infection and triggers inflammation. A systematic inflammatory response is triggered, and it will release cytokines and inflammatory mediators that can further damage the tissue. organs. For the sixth step now, after the compensatory failed and the failure of the organs has progressed and the condition is so severe, now the sixth stage is irreversible and there's multi-organ dysfunction right now. And this might bring about widespread cellular death, which is prolonged ischemia. And ischemia is the tissue damaged in the bodies. It might also lead to organ failure. It might also lead to cardiac depression. And also, it might lead to disseminated intravascular coagulation. And that stage is irreversible. Hereby, now this after cellular death, now the organs will start shutting down slowly by slowly because the compensatory mechanism could not be effective. Cardiac depression simply means that there's reduced coronary perfusion and the inflammatory mediators has depressed the heart contractility and has worsened now the cardiac output of blood. Disseminated intravascular coagulation, simply the DIC. This is a severe clotting disorder and it can occur leading to widespread microthrombi and bleeding throughout the body. Now, and that is now what takes place if shock has not been effectively handled and has not been compensated for. We'll now go to the general signs and symptoms. And these signs and symptoms will vary depending on the causes of those shocks, of the shock that might take place. The first one is hypotension. As you know, the systolic BP, 90 millimeters of mercury, or mean arterial pressure, 65 millimeters of mercury, or a drop of that to 40 millimeters of mercury from the baseline. Another sign is the tachycardia, which is the rapid heart rate, which is now a compensatory mechanism for the shock because it slows the heart rate. Now, it tries to make it rapid so that the blood is pumped faster to compensate for the inadequate oxygen supply. Also, another sign is tachypnea, which is rapid breathing, to also compensate by enabling the blood to have like more oxygen by taking in more oxygen. Another sign is the cool or clammy skin, but this does not display itself in the early stages of distributive shock. As you know, I told you earlier, distributive shock is when blood vessels widely dilate, leading to hypovolemia, which is decreased blood volume. Another sign is oliguria, which is reduced urine output, because when shock takes place, for a compensatory mechanism, we had initially said that the ADH system and the RAAS system take when that compensatory mechanism has not taken place, there's like little amount of water and sodium in the body. That's why urine output. The metabolic acidosis, and these are adequate oxygen delivery, which is required to break down the lactic acid. Under the types of shock and pathophysiology, there are four types of shock. The first one is hypovolemic, which is now inadequate circulating blood volume. Like there's little amount of blood which causes the blood volume to be low. And causes of this might be hemorrhage, which is a significant amount of blood loss. And this blood loss, hemorrhaging might take place when there's been trauma, maybe there is ruptured aneurysm, postpartum hemorrhage, or also burns. Burns might also lead to severe bleeding or also internal bleeding. There's also fluid loss. This is non-hemorrhaging, but it also leads to hypovolemic shock. This might be caused by severe dehydration, maybe due to vomiting or diarrhea. Severe burns falls under non-hemorrhaging, whereby there's loss of plasma, or also the diabetic ketoacidosis, or third spacing, which is peritonitis or pancreatitis, whereby there's swelling of maybe the pancreas or the peritoneum. The pathophysiology of hypovolemic shock is simply that there's decreased preload and also or the decreased stroke volume or decreased output, whereby the body attempts to compensate by vasoconstricting and increasing the heart rate, but inadequate blood volume will lead to widespread hyperperfusion, which is the reduced flow to an organ and might lead to organ dysfunction or organ failure. The second type of shock is cardiogenic shock, which is defined as failure of the heart to pump adequate blood despite there being sufficient blood volume. The causes of this cardiogenic shock might be due to myocardial infarction, and this is the most common. Myocardial infarction is whereby the heart muscles are failing to pump sufficient blood, and might be due to extensive myocardial damage, or also another cause is severe heart failure, as we've been taught yesterday about heart failure. It might also be caused by heart disease, whereby the acute matrix regurgitation or aortic stenosis. Another cause of is arrhythmias, where the normal rhythms in the heart. This is due to sustained bradycardia or tachycardia. Cardiogenic shock might be caused by, as you remember, bradycardia is when the slower heart rate or a faster heart rate. Cardiogenic shock may be by myocarditis or stenting. Myocarditis is simply the swelling of the myocardium. The pathophysiology of this cardiogenic shock is simply primary myocardial dysfunction or decreased cardiac contractility. This is explained by the myocardial infarction, whereby the muscles fail to pump blood, or also decreased stroke volume, or there's decreased cardiac output, whereby the heart cannot effectively pump blood forward, and it will lead to both inadequate systemic perfusion, like there's inadequate blood flow to other organs, or also pulmonary congestion, like there's low blood. Compensatory mechanism of this shock is vasoconstriction, which increases the afterload, and it might further strain the heart, which would lead to heart failure. For the third kind of shock is distributive shock, which is defined by widespread vasodilation, increased capillary permeability, and might lead to a relative hypovolemia. And hypovolemia this hypovolemia means that the organs are receiving blood, yes, but the volume of blood is like insufficient. The types of this distributive shock, it's like septic shock. The first one is septic shock, which is caused by systemic infection, and this systemic infection will trigger inflammation like the infections might be bacterial, might be fungal or viral, and it lead to inflammation. Inflammation of the vessels will make the volume of the blood to be decreased. The second type of shock under distributive shock is the anaphylactic shock, and by a severe allergic reaction, and it lead to massive vasodilation. This massive vasodilation, or also it might lead to increased vascular permeability. Another type of shock, distributive shock, is the neurogenic shock, and this is caused by the brain trauma or spinal cord injury, which will disrupt the autonomic nervous system and lead to loss of vascular tone. Another type of shock under distributive shock is the drug-induced shock. Either is overdose of vasodilators or the anesthetics. That is self-explanatory. For the fourth type of shock is the obstructive shock, which is defined by the physical obstruction of blood flow, as it is called obstructive shock, either out of the heart or in the major vessels, and this will impair cardiac output. The heart itself is capable of pumping, but the flow is blocked along the system. The blood is flowing, yes, but the heart is pumping, but the flow is blocked. And this obstructive kind of shock might be caused by a pulmonary embolism. Pulmonary embolism will obstruct the pulmonary artery, and it will increase the right ventricular afterload. Also, another cause of obstructive shock is cardiac tamponade, whereby there's an accumulation of fluid in the pericardial sac, and it will compress the heart, and it will prevent adequate ventricular filling. Another cause of this obstructive shock is tension pneumothorax, whereby air in the pleural space will collapse the lung and shift the mediastinum, and it will compress the vena cava and the heart. It will put pressure on the vena cava, thereby pressure on the heart. Another cause is the aortic stenosis, and this is obstruction to the left ventricular outflow. Another cause is the coarctation of the aorta, whereby the aorta is narrowed down, which will lead to insufficient blood that is supplied throughout the body will be limited, thereby the oxygen will intake along the blood will be reduced. The pathophysiology of this obstructive shock is the mechanical impediment to blood flow will be decreased, thereby decreased preload, or there will be significantly increased afterload. The heart will struggle against the obstruction, and it will lead to systemic hypoperfusion. Under the general management principles of shock, it is explained by that early recognition and rapid intervention, whereby it is called the golden hour. This is the effective measures taken after the shock has taken place. It involves air shield, whereby there is airway, breathing, and circulation. You protect the airway to enable oxygenation, fluid resuscitation for the hypovolemic or some distributive shocks. But in cardiogenic, you need to be cautious. Also, there's vasoactive drugs like the norepinephrine to support the blood pressure if fluids are not sufficient. Under management, we identify the cause of shock, and then we treat the underlying cause. For the hypovolemic shock, which is decreased blood volume, we simply stop the bleeding, which is the hemorrhaging now. Whereby there has been a significant blood loss, you will stop the bleeding and then you replace the lost fluids or the blood. For the cardiogenic shock, whereby the heart has failed to pump blood effectively, you reperfusion for the MI, or you offer mechanical support to the heart to enable it to pump more blood. For septic shock, which is caused by infection which has triggered inflammation, you offer broad spectrum antibiotics, which will enable the inflammation to reduce. For the anaphylactic shock, which is a severe allergic reaction and it will lead to massive vasodilation, you offer vasoconstrictors like the epinephrine, the antihistamines, which as you know, antihistamine is for allergic reactions, and as you know, this kind of shock is caused by a severe allergic reaction. So the antihistamines will help to counteract that allergic reaction. You might also offer corticosteroids. For the neurogenic kind of shock, which is caused by brain trauma or spinal cord injury, and it will disrupt autonomous nervous system, you offer vasopressors or sometimes atropine for the bradycardia, which will enable to increase heart rate. For the obstructive kind of shock, as you know, which is caused by a blockage that affects the blood flow, you will relieve the obstruction. Maybe you needle compress in a pneumothorax, maybe due to an embolism. You might need to that procedure for the embolism. And the name. But you can offer pericardiocentesis for the tamponade. You can offer needle decompression for tension pneumothorax or thrombolysis for PE, for the pulmonary embolism. Yeah, it's called thrombolysis. I forgot it. You can also offer supportive care for the organ support. Maybe once the shock has really affected the heart, you can offer support to the heart to enable it to pump more blood, to enable to stop the perfusion. Or you can offer metabolic management, or you can control temperature. Thank you so much. Done with my presentation.
Thank you, Naomi. And if there is inadequacy in tissue perfusion, you will think of the very many processes now, or what takes place with the body tissues. They talk about hypoxia, cellular hypoxia, metabolic dysfunctions, and if it's prolonged, if the tissue perfusion inadequacy is prolonged, you'll be thinking about organ failure and also death. So generally, for all the generally, when we talk about pathophysiology of shock, from a general perspective, could be there's that triggering event. That's the triggering event for the various types of shocks. It could be hemorrhage, could be infection, could be heart failure. With that, there'll be reduction in circulating volume, also reduction in cardiac output, reduction in tissue perfusion. So, which now, of course, now will lead to reduction in oxygen that is delivered to the various cells, and then that will switch, of course, to anaerobic metabolism, which will increase the lactic acid in the cells, just as you put it. And then, of course, there'll be cellular dysfunctions, cellular injury, organ dysfunction if it's left untreated, multi-organ failure, and progressively leads to death. We have the four major types of shock which you have presented to us: the hypovolemic shock, because of loss of blood volume, which could be as a result of hemorrhage, could be as a result of burns, dehydration. With hemorrhage, there'll be reduction in the preload, reduction in the stroke volume, reduction in cardiac output, and eventual reduction in tissue perfusion, which follows the general mechanism of the pathophysiology that we've just talked about. The cardiogenic shock, where there is pump failure, which could be caused by some of the conditions we talked yesterday, the heart failure, the myocardial infarction we talked about yesterday, the arrhythmias, which is has to do now with the electrical activity in the heart. Again, now with those etiologies, they will affect now myocardial contractility. So the myocardial tissues from contraction will be affected. There will be a reduction. If there's reduction in myocardial contractility, there will be reduced cardiac output, even if there is normal volume. Of course, now leads again now to reduce the tissue perfusion, organ failure, death. The distributive shock, abnormal distribution of blood flow because of vasodilation, which has various types, like the septic shock, which is as a result of infection, anaphylactic shock, which is as a result of allergic reaction, neurogenic shock, which is as a result of injury to the spinal cord, and then of course obstructive shock, where there is obstruction of blood flow, could be from like things like the pulmonary embolism, tension pneumothorax, which of course is going to reduce the venous return or reduce cardiac output, then eventually lead to reduced perfusion. And all these are mostly characterized by hypotension. Tachycardia will be present in all of them except for the neurogenic shock. Cold, clammy skin could be seen. Altered mental status in your patient, decreased urine output, increased lactate levels, which will be a marker for anaerobic metabolism. Any question on shock? Any question? Okay. If there is no question, then yes, is there a question? Chris, your hand is up.
Yes. Yes, I have a question. Okay, how does it differ? How does shock differ from simply someone being surprised or even scared?
Sorry?
My question is my question is about, okay, I was asking, how does shock differ from somebody feeling shocked, someone feeling scared or surprised?
Now you are, what you are referring to is shock and emotional response. I'm shocked. Now you can, your classmates are just laughing in the form of emoji. You are shocked. Are you shocked this morning, Chris? So that is now shock, which we refer to as an emotional response. You can see even your nurses club is even shocked now. So that shock is emotional response, but here you are talking about now shock, a medical condition. Very interesting question. Another question could be also as interesting as Chris's moment of shock. Another question? Okay. If there is none, then or can shock kill someone? I believe that has already been said. If you look at the pathophysiology of shock, shock is very fatal. Actually, it kills very fast if there is no intervention. More especially in some of these types of shock, like so you're talking about hypovolemic shock. If there is decreased output, decreased tissue perfusion, we are talking about organ failure, multi-organ failure, which leads to death. If you talk about septic shock, where there is serious infection, leads to massive vasodilation. If left untreated, again, leads to immediate death. So shock, yes, kills, and it's very fatal, very quick. It needs quick intervention. If it's hemorrhagic shock, you need to identify the cause of the hemorrhage and arrest the hemorrhage immediately. If not, you will lose your patient. If you're talking about anaphylactic shock, you've heard of people dying from being stung by bees. That's anaphylactic shock. So if intervention is not given immediately, yes, it's very fatal, kills very fast. What organ is the first to be affected? It all depends on the type of shock. It all depends on the type of shock. But again, we are talking about the vital organs. We are talking about the heart, we are talking about the liver, we are talking about the kidneys. What is the difference between shock and stroke? Who can differentiate for us shock and stroke? I believe we mentioned stroke yesterday. So, shock, when talk about shock, which has already been defined, basically a life-threatening condition which is caused by inadequate tissue perfusion. And the inadequacy in terms of tissue perfusion can be caused by various causes. We have talked about the hemorrhagic shock, which is because of loss of blood volume. We have talked about cardiogenic shock because of pump failure. We've talked about things like septic shock because of an infection, anaphylactic shock because of allergic reaction, obstructive shock because of physical obstruction to blood flow. So that is shock. Then when we talk about stroke, that is now disruption of blood flow to the brain. So that differentiates that. So basically, with stroke, there is now disruption of blood flow specifically to the brain. Okay, so if there is another question, let me go now to the next group of presenters. So we are done with that's it for the cardiovascular conditions. Let's go to the endocrine conditions.